everyone, and welcome. If there's one topic that just loves to show up on your micro exams, it's got to be MRSA. So today, we're not just going to learn about it. We're going to build the perfect high-yield answer together, step by step, so you can absolutely crush it. Okay, let's frame this whole thing around that one big question. When you're in the exam hall and the clock's ticking, how do you put together an answer that hits all the key points? Well, this is your blueprint for getting those maximum marks. Let's do it. So here's our game plan. We're going to start with a solid definition, then get into the nitty-gritty of how it becomes resistant. After that, we'll compare the two main types, walk through the diagnosis, and finish strong with treatment and control. It's a super logical flow that examiners love to see. First things first, let's nail down the definition. This is the foundation of your entire answer, so you want to make it crisp and 100% accurate. Right, let's lock this in. MRSA isn't some brand new bug. It's a specific, really tough strain of good old Staphylococcus aureus. And the key phrase here, the thing that makes it so dangerous, is its resistance to all beta-lactam antibiotics. That's your penicillins, your cephalosporins, the whole family. And that's exactly why it's so hard to treat. That's your perfect opening sentence right there.
Now for the cool part, the science. If you really want to impress the examiner, you have to explain how MRSA actually resists these drugs. This is where you show you got that deeper understanding.
The whole story of MRSA resistance really comes down to one single thing, a gene called the MECA gene. And get this, it's not even a native gene. It's an acquired piece of code, basically. Think of it like the bug picked up a powerful weapon upgrade that turns it from a regular enemy into a final boss.
Okay, so here's how it works. Picture this. A normal staph cell has these things on its surface called penicillin-binding proteins, or PBPs. You can think of them like locks. Our beta-lactam antibiotics are the keys that are designed to fit into those locks, jam them, and stop the bacterium from building its cell wall. Simple enough, right? But the MECA gene is a game changer. It gives the bacteria the instructions to build a totally new, modified lock called PBP2A, and our old antibiotic key, it just can't fit anymore. It bounces right off. The result? The bacterium keeps building its cell wall, completely unharmed.
All right, next up, to really take your answer to the next level, you need to know that not all MRSA is the same. We basically split it into two big categories, and it all depends on a simple question. Where did the person get the infection? Now, check out this interesting trade-off. Community-associated MRSA, the kind you get out and about, is often way more aggressive. It's more virulent. Why? Because it often carries this nasty little toxin called PVL, which literally punches holes in your white blood cells. This is what causes those really bad skin abscesses. On the other hand, hospital-associated MRSA is usually a bit less aggressive, but it's a master of defense. It's often resistant to a whole bunch of other antibiotic classes, making it an absolute nightmare to treat in patients who are already sick.
Great, we've defined it, we've explained the mechanism, we've covered the types. So how do we actually prove a patient has it? Laying out the lab workflow shows you have a really complete, practical grasp of the topic.
Your first stop in the diagnostic journey is always the direct smear. You take a sample, do a gram stain, and under the microscope, you're looking for that classic textbook image, gram-positive cocci in grape-like clusters. That's a huge clue you're dealing with Staphylococcus. Next up is culture. And for those extra marks, you want to mention two key things you'll see. First, on nutrient agar, you get these beautiful golden yellow colonies. That's where the aureus in its name, meaning gold, comes from. Second, on blood agar, you see this clear zone around the colonies called beta hemolysis. That tells you the bacteria is actively destroying red blood cells. Now for the killer confirmatory test. This is the one that separates S. aureus from its less dangerous cousins like S. epidermidis. It's the coagulase test. See, S. aureus is coagulase positive. It produces an enzyme that makes blood plasma clot up. When you see that clot form in the test tube, you know for sure you're dealing with S. aureus. So we've confirmed it's S. aureus, but now for the final piece of the puzzle. How do we prove it's the MR part, the methicillin resistant strain? Well, we've got a few tools. A common one is using a cephalococcin disc on the culture plate. It's a great screening method. But the absolute gold standard? That's PCR, because it directly hunts for the MECA gene itself. No guesswork. Finally, to bring it all home, you have to talk about what we actually do about MRSA. How do we treat the patient in front of us? And just as important, how do we stop it from spreading to others?
This right here is a non-negotiable high-yield fact. You have to know this. For any serious invasive MRSA infection, the #1 drug of choice is vancomycin. Simple as that. It's the cornerstone of therapy.
But what if you can't use vancomycin for some reason? For those bonus points, you need to list a few alternatives. Now, this is a pretty long list, so how about a little mnemonic to help you remember it? Just think tall doctors like tea and quinoa. That's for teicoplanin, daptomycin, linezolid, telavancin, and quinupristin/dalfapristin. And you must add this critical point. You always have to be guided by antimicrobial susceptibility testing.
And last but not least, prevention. Controlling MRSA in a hospital is all about a multi-pronged attack. You hit the main points by talking about screening people for it, treating carriers to get rid of it, using things like mupirocin, and the absolute foundation of it all, strict infection control protocols, like obsessive hand hygiene and isolating patients. And there you have it. That's your complete, A+, well-structured short note on MRSA. From the definition all the way to control, you've hit every key point. And just to leave the examiner really impressed, you end with a look to the future. Because with new threats like vancomycin-resistant staph emerging, it shows us this battle is really far from over.